Without further ado, let me introduce Dr. Kondapalli. She completed her undergraduate degree at the University of Michigan and received her medical degree from the University of Vermont College of Medicine, where she was the recipient of the Carby Award. During her residency training in obstetrics and gynecology at Northwestern University, she received the Michael Newton Award for Clinical Excellence in Obstetrics and Gynecology. Following residency, she completed a postdoctorate research fellowship in reproduction biology at Northwestern University. She explored the long-term consequences of cancer therapy and ovarian function and fertility, with a particular focus on improving fertility preservation options for cancer patients. In addition, Dr. Kondapalli completed her reproductive endocrinology and infertility fellowship and received a Master of Science degree in clinical epidemiology at the University of Pennsylvania in 2011. In August 2014, she joined the Colorado Center for Reproductive Medicine. Dr. Kondapalli is board certified in obstetrics and gynecology and the subspecialty reproductive endocrinology and infertility, and is a fellow of the American Congress of Obstetricians and Gynecologists. Welcome.
Thank you so much for that very nice introduction. And then I also want to thank the YSC committee for inviting me to present on this really important topic. And thank you for all of you who are troopers and stayed until Sunday to join us for this session. As you heard, I'm a reproductive endocrinologist and infertility specialist, and I specialize in cancer and fertility. It's something that I was inspired to do when I was a resident at Northwestern, and I continue to do it during my fellowship and as my career. And now I practice in Denver, Colorado, where it is 20 degrees. So I'm so pleased to be here with all of you, and so sad that I'm going to have to travel back home later this afternoon. This is going to be an informal session. I only have about 20 slides, and so I do welcome questions. So if you have them, if you want to raise your hand as we're talking, that is fine with me. We'll just pass out the microphone. And what I may do is actually use this mic. Can everyone hear me? Perfect. Okay, great. So for today's session, over the next 45 minutes or so, these are the questions that we're going to be answering. Okay, perfect. So the objectives of this session are to answer these 4 questions. How does breast cancer treatment affect fertility for women? I also want to help you understand how to figure out if I'm fertile, what Parenthood options are available to me, and then also answering that question about safety of pregnancy after treatment. So with question number 1, how does breast cancer treatment affect fertility? So these are the different factors that I think about when I see a young patient who comes to see me, either at the time of their diagnosis and they're thinking about fertility preservation options, or if they've gone through treatment, they didn't have an opportunity to maybe freeze eggs or embryos, and now I want to give them an assessment about how toxic or how did their cancer treatment affect fertility and reproductive function. These are the 4 components that I think about when I give patients a risk profile. The biggest factor associated with fertility risk is the age of diagnosis and when a woman was treated. What we know about female fertility, which is so different from male, is that women, we are born with all the eggs that we'll ever have in our whole life. And then over the course of our lifetime, we lose eggs. So the older that we are, and if we get diagnosed, just inherently because of your age, you are going to have fewer eggs. So for example, a young woman who comes to see me at age 32, maybe she has a new diagnosis of premenopausal breast cancer, I already know with her walking in the door that she has fewer eggs than my 24-year-old patient that came in maybe last week, just because fertility or egg quantity declines as we get older. The other big factor is going to be the specific treatments that a patient gets. So different types of chemotherapies or radiation will have different risk profiles depending on how toxic they can be to the eggs that are within the ovary. And along with that, the cumulative dose. So a patient who is getting multiple courses of chemotherapy, over their lifetime, they will have a much higher dose than someone who gets 4 cycles of a specific treatment. And then the duration of treatment. So dose and duration go together, but really the 2 key factors are going to be age of diagnosis and the specific agents that are used. So let's talk about age of fertility. So people think there is this biological clock, and I think that the media and some of us in medicine try to debunk this theory, but it is true. There is a finite window for female fertility, and this is a nice graph. So this is looking at probability of pregnancy at different percentages over the course of our lifetime. And what you see is that that cusp really does happen for women who are in their mid to late 30s, that the probability of pregnancy, and this is natural conception, does decline, and you can see this pretty steep decline that occurs for women who are over the age of 35, and this is natural fertility. This is not associated with cancer or cancer treatment, but this is just what happens normally in female reproduction. And then the black line here, this graph is showing the likelihood or probability of infertility. And infertility, the diagnosis of infertility is age dependent. So a woman who is under the age of 35, infertility is diagnosed by 12 months without contraception, attempting pregnancy without a pregnancy. For women who are 35 and above, it's actually 6 months, and it has to do with the fact that at age 35, the probability of pregnancy is already reduced. So the window of time for waiting for someone who is 35 and older is only 6 months, and then the recommendation is to undergo some fertility testing. So the probability of infertility starts to increase right at age 35 and really steeply increases for women who are 40 and above. As I said earlier, women are born with all the eggs that they'll ever have in their whole life. That blew me away when I was in medical school. It's the physiology of female reproduction is so interesting. The eggs, so this is a cross-section. So this is a pathology slide of what the ovary looks like. And for women, the ovary is actually only the size of a walnut. So it's only about 2 or 3 centimeters, and all the eggs in the ovary are on the surface. So this is a picture of what the surface, it's called the cortex. It's only about 2 to 3 millimeters in depth. Super, super thin. What I describe it as is like the skin of a grape. You know how thin a skin of a grape is? That's the skin of the ovary. And all the eggs that we'll ever have are in that cortex. And the eggs that are within the ovary, the majority of them are in this quiescent or early stage of development. They're actually immature eggs, and that's what's depicted here. So these are actually eggs. They're contained in a structure called a follicle. That's the functional unit of the ovary. It's an egg with some supportive cells around it, and you see how some of them, especially the ones that are here near the surface, are tiny, right? They're small, and then these are those eggs. They're larger. Those follicles are expanded. We have hundreds of thousands of follicles that are essentially asleep. Those follicles make up what we call the ovarian reserve. So that may be a term that you have heard before, but those are these immature follicles that are in the sleeping state. Once a girl goes through puberty, there's some sort of mechanism within the ovary. We actually haven't identified what that key component is, but that I call it an alarm clock. That alarm clock will wake up or recruit a group of follicles every month. And that's what's depicted here. So this is a group of follicles that have been selected in a single menstrual cycle. So let's say for a particular woman, she has hundreds of thousands of sleeping eggs, and in a particular month, for example, like this one here, 10 of those follicles get recruited. Among those group of 10, 1 is the chosen one. One of those follicles is destined. So let's pick out maybe this follicle here. One follicle is destined to be the dominant follicle. That is the one that a woman will ovulate during that menstrual cycle. Anybody have an idea about what happens to the other 9 that did not get selected? Well, they're gone. Exactly. You lose them. They essentially die off. So it's such an inefficient process, the way that female reproduction and physiology works. So many follicles are recruited, 1 is mature, the rest die off. We don't quite know why that 1 gets selected while its neighbor, so for example, this follicle was destined to die off. It probably has something to do with the quality of that egg, so probably the DNA is a little bit better. It also may have something to do with the way that follicle responds to hormones, so maybe it's just responding a little bit better. But this follicle was the one that's destined to ovulate, and the others die off. So super inefficient. That physiology is really important when I think about how do different types of chemotherapies affect egg quantity or this ovarian reserve. There will be some chemotherapeutic agents that affect the growing follicles, in which case I'm not that worried because you only got one that was going to ovulate. 9 out of 10 would have died off anyways. So if I have an agent that is affecting the growing eggs, I'm not that worried because you're essentially losing one egg a month. Does that make sense? I care about the chemotherapeutic agents that affect the follicles that are asleep. There are no stem cells within the ovary. Women cannot make new follicles. So once these sleeping eggs are destroyed, they're gone. You can't make new ones. So with that information, I can kind of think about different types of chemotherapies and put them into different categories, and we're going to talk about that. This is a really nice graph that I like, and it's kind of scary too, because I saw this in medical school too. So this depicts, on the y-axis here, is the number of follicles over our lifetime, and then age is on the x-axis. Here, at age 0, that's actually birth. And what you see is that there's a spike. You see how many follicles there are even before birth. So what's interesting is that girls have the most eggs they'll ever have in their entire life in the womb. So when a woman is about 20 weeks pregnant, which is about 4 or 5 months pregnant, and she has a female infant, that infant has the most eggs that she'll ever have in her whole life. In utero, girls have about 7 million eggs within the ovary. There is some sort of process within the ovary that eggs die off in utero, so that when that girl takes her first breath, she is only born with about 1 million eggs. 5 to 6 million eggs have already declined and died off in the womb before she even takes her first breath. Despite the fact that children, so toddlers, young girls, their ovaries are not working, they're not producing hormones, they're not menstruating, they're not ovulating, this process of egg loss continues, so that when a girl enters the reproductive window, which is puberty, the average age of puberty is around 12 or 13, she is left with only 300,000 eggs. So she started with 7 million, and even before entering that reproductive window, 90% of those eggs have already been destroyed. So you start off with 300,000 at puberty. The average age of menopause is age 51. And if you look across decades and even worldwide, that seems to be pretty true, that despite changes to nutrition, detection, if you look at different countries, women usually go through menopause at age 51. But what we're finding is that it's not about chronologic age. It's not how old a woman is. It has to do with how many eggs remain in the ovary. And that critical number is 1,000. So when a woman reaches 1,000 follicles within the ovary, she's going to go through that menopausal change. It doesn't matter how old she is. And what we see is that women who've had cancer treatment, so the impacts of chemotherapy and radiation can actually shorten that time to menopause in that reproductive window. So we used to think that the reproductive window was puberty to menopause, age 12 to 13 to age 51, but that window can be really truncated if a woman's been exposed to different types of agents. And she could actually go through menopause at age 30, 35, 40, 3 years earlier. All depends on what type of treatment was given. So when I think about different types of chemotherapeutic agents, I classify them into 3 categories. The ones that I'm super worried about, the ones that are sort of worried about, ones I don't worry about very much. The chemotherapies that are in this high-risk category, so depending on the dose and duration of treatment, the ones that I get most concerned about are alkylating agents. So a medication like cyclophosphamide, it's an awesome drug. It treats so many different types of tumor cells. It treats so many other types of medical illnesses. It's one of the medications that can be used for breast cancer. It's used for lymphoma. It's used for leukemia. It actually can also be used for lupus. So it's an excellent chemotherapeutic agent because it's so effective, but it's the one that I am most concerned about because it doesn't care about those follicles that are starting to wake up and grow. It goes after the sleeping follicles. And those were the ones that we talked about, that once those are destroyed, you can't make new ones. So women who've been exposed to high doses of Cytoxan or cyclophosphamide are the ones that I am most concerned about with fertility risk. And one of the consequences, depending on the dose of the medication, could be something known as premature ovarian failure. Now the new terminology is called primary ovarian insufficiency, but it's actually where that window from puberty to menopause is really, really narrow, and a woman actually loses all of those eggs or has already reached 1,000. Yes? Well, it depends on how old you are. So the question was, what would be considered a high dose of cyclophosphamide? It all depends on how old you were. Because the same dose of cyclophosphamide for somebody who's 18 years old is not going to be as toxic as somebody who's 36, because where she is on that reproductive timeline. So it all depends there. That's a great question, though. The medications that we consider are moderate risk are ones that are adriamycin, or doxorubicin is the other name for it, carboplatin, and Taxol. The concerns we have about any type of platinum-based chemotherapeutic agent, which is what carboplatin and Taxol are, is the way that they work is that they bind to the DNA within tumor cells. And DNA is basically two springs that are connected together by bridges. And what these medications do is prevent those bridges from forming. And so the tumor cells can't make the DNA and they can't replicate, so they stop growing. These are excellent medications, but they're not specific to breast cancer cells or to tumor cells. They can actually affect DNA within normal cells. And the DNA that is within eggs are very, very sensitive to everything that we're exposed to. That's why it's harder for women as we get older to conceive, because the DNA within eggs actually go through a natural aging process that happens, and medications such as carboplatin or Taxol can accelerate those changes to DNA. Some of the newer medications, so Herceptin and Taxotere, we actually don't have a ton of data because these are relatively new medicines, so we don't have a lot of long-term information regarding impact. And so I put it in here with a question mark. And some of the impacts that we can have is impaired fertility. So, about 30% of women who get, depending on the cumulative dose, can have impaired fertility, so difficulty conceiving or pregnancy. And then amenorrhea, which is stopping getting periods altogether, so no periods. The medications that I'm less concerned about are medicines such as, these are in the low risk category, 5-fluorouracil, methotrexate. These medicines or these agents affect the growing follicles. And remember, there's only a group of them that will get recruited every month. And so I'm less worried about these medicines in terms of long-term impacts, because the sleeping eggs are being protected. Some of the side effects that can happen with this is that a lot of my patients will stop getting their periods while they go through treatment. Very, very common. That's nothing that I'm worried about. And then there's oftentimes this interval of recovery. So about 4 to 6 months, they may start getting their periods again, and their hormones will be kind of back in sync. That window of recovery can even happen up to 12 months, so I don't worry if a patient hasn't gotten her period back and it's been up to 12 months. Let's talk a little bit about periods, because I have a lot of patients who get very worried about whether or not they get a period or they don't get a period. From a fertility standpoint, whether a patient has her period or not really doesn't make me feel reassured or worried. So there was an important study that came out about 5 years ago. This is a study looking at women who resumed menstrual cycles, so women who went through treatment, got their periods, and if we look at clinical diagnosis and objective markers of infertility, what this study showed is that we're actually underestimating the amount of infertility that exists in survivors despite what happens with their menstrual cycle. So even if they're getting their period regularly, that we're actually identifying infertility a lot more if we look at objective diagnostic criteria for infertility. So for example, if we have, so this is looking at women with different types of cancer. The blue bar here, the diamonds, or these purple ones, are breast cancer survivors. So if we look at a breast cancer survivor who's about 35 years old, 35-year-old who is getting her periods, we're actually about 25% of them meet the clinical diagnosis of infertility despite having regular periods. And there's an age-dependent effect here, so that that same person who is 37 years old who's getting regular cycles, 60% actually have infertility. So whether a patient gets a period or doesn't get a period, it doesn't give me real insight about their underlying egg quantity or infertility. Yes? Yes. Yes. Perfect question. Yes. The inverse is true as well. So a patient who doesn't get their period, I am not worried about either, because then I can do objective testing for egg quantity. Yes. So periods or menstrual cyclicity alone is not a factor that I use to feel reassured or worried. Great question. Absolutely. There are women who are not going to get their period and then they have a natural conception. Absolutely. Great question. All right, so that is a great segue into figuring out, am I fertile or do I have eggs? That's what we're answering here. And when I have a patient who comes to me and maybe went through cancer treatment, didn't have a chance to freeze eggs, but now wants to know what her fertility status is, there are a combination of blood tests that we can do, and I can do an ultrasound to get a sense of egg quantity. So serum markers, so these are blood markers of ovarian reserve. So when we talk about ovarian reserve, these are surrogate markers. These are ways that I can reflect what's the number of sleeping eggs we still have. Okay. So there are some hormones that we can do. So this is a diagram of the brain. There's a special place in the brain called the hypothalamus. The hypothalamus is sort of the conductor. It kind of runs the show. The hypothalamus essentially speaks to the pituitary gland, and the pituitary will send out these hormones. One of them is called follicle-stimulating hormone. There's another hormone called luteinizing hormone. These two hormones talk to those follicles that have been recruited. So they're talking to the ones that are awake and starting to develop and selecting that one dominant follicle. As those follicles are developing, now you have hormones from the ovary. One of them is called estradiol, or estrogen. There's another hormone called Antimullerian hormone, or AMH. If I test these four hormones, I can get a sense of how the brain and ovary work together. Indirectly, it tells me about egg number. And the way that we use these hormones is that as women start losing eggs over their lifetime, her brain starts to sense it. And so her brain, these pituitary hormones, go into overdrive. It's almost like putting the foot on the gas, because it's saying, gosh, the pituitary is recognizing that there aren't that many eggs, so it has to send more and more brain signals to get the few eggs to grow. So when these hormone values start to go up, it's actually not a good sign, because it's telling me inversely that the egg quantity is declining. We have this newer test called Antimullerian hormone, or AMH. This is a hormone that has been developed over the last 5 to 10 years, and this is becoming probably our most popular fertility test. This is a hormone. It's released by the cells that surround the egg. So remember we talked about the follicle. It's an egg with some supportive cells around it. Those supportive cells secrete AMH, and it reflects the number of follicles a woman has. It's a direct marker. The more eggs a woman has, or more follicles, the higher the AMH. It's a really easy blood test to do, so it's a simple blood draw. It doesn't have to be timed with a menstrual cycle. Some of the other hormones have to be done cycle day 2 or 3 of a period. If you have somebody who doesn't get periods, it's going to be hard to know when to do that testing, so AMH would be an alternative option that would be appropriate for that patient. And I get worried if that AMH value is less than 1. Then that makes me concerned that a woman is starting to lose eggs at a faster pace than I would expect. The nice thing about AMH, so this is looking at different menstrual days from ovulation, and you can see that the AMH value is really steady. So if I took a woman and drew her AMH multiple times during the same menstrual cycle, I'm going to get the same value. And then if I also did that AMH between different months, it's also really, really stable, and that's what this graph is showing. So it's become one of our better fertility markers, or markers for egg quantity. And what we see is that, so this is in the general population, looking at AMH values. So when we're young, so this is somebody who's in their early 20s all the way up into their 40s and 50s, and you can see this natural decline that happens, and it corresponds to women losing eggs over their lifetime. So you can see that AMH is really robust in women who are in their 20s, and then you start to see that decline at age 35, 36, and really goes down as a woman is approaching menopause. And this corresponds to the egg quantity and what we know about natural decline in egg health. This is also, this graph here is looking at serum AMH levels before chemotherapy. So we can test women before they go through treatment, and you can see their number is, the majority of them are going to be above 1. Right after chemo, all those follicles that are essentially in the pipeline that are starting to develop, those can be affected by chemotherapy. So AMH naturally is going to decline and maybe even be 0. And for some women, there's going to be a window of recovery that can be about 4 to 6 months, and we start to see the AMH increase. But this is an interesting study here that shows that even 2 years after chemotherapy, at least in this group of patients, their AMH was still quite low. So it didn't quite recover back to their pre-treatment levels. The other thing we can do besides blood tests is actually an ultrasound. So this is a transvaginal ultrasound. This is a picture of the ovary. The ovary is relatively small. These bubbles are follicles. They look like bubbles. Eggs are microscopic, so you can't see them, but the follicles look like bubbles. So I can actually do something known as an antral follicle count. I can count up how many follicles were recruited in a single menstrual cycle. So in our example patient, we said 10 got recruited. For this patient, it looks like maybe even 12 to 15, which is a robust number. We are measuring follicles. They are anywhere from 2 to 9 millimeters. They reflect the remaining eggs within the ovary, and they are also a direct correlator to the number of eggs that still remain within the ovary. The fewer eggs that we have, this follicle count is going to go down over time. So this is also going to give me a sense of egg quantity here. The last thing that I want to say about these blood tests is that, what do the tests mean? Because you always have to interpret these in context. So these blood tests provide a snapshot in time. It provides me, in 2018, let's say February 2018, this is what a woman's ovarian reserve looks like. It is a terrible, none of these values or none of these tests are great predictors of women who are going to go on and have a natural conception. Terrible predictors of that. They also are not great predictors of time to menopause per se. So for example, if I have a patient who has an AMH of 0.5, I can't predict that she's going to go through menopause in 3 months, 6 months, 5 years. It just tells me what things look like today. Now if I were to do serial blood tests over time, then I can kind of create a trend, but a single blood test won't provide me that information. It will give me insight about the likelihood of response to fertility treatment. So if I have a patient who comes to me for things like assisted reproduction, based on her AMH and what her follicle count is, I can get some insight about how I think she's going to respond to the fertility drugs, and it helps me counsel patients about what's the likelihood that assisted reproduction is going to be successful. So that's how it can be really helpful. And then it must be interpreted in the context of age and medical history. So age is going to, this is a common theme that we're seeing, is that age is going to be really important when we're thinking about female fertility and how to interpret these blood tests and numbers. There are some other fertility tests that can be done, and I just put 2 of these here. If I have a couple who is trying to conceive on their own, and she's a breast cancer survivor, her numbers look pretty good, and she's still having difficulty conceiving, there are some additional tests, because we also want to make sure that her anatomy looks normal. So there's a special, and that her fallopian tubes are open. Natural fertilization happens in the fallopian tubes. So I may have a breast cancer survivor who's having infertility, and she's 5 years out of treatment, her numbers look good, but then I find out that maybe her tubes are blocked. And it had nothing to do with her cancer treatment in itself, but more anatomy. So there's a special type of x-ray that can be done. This is called a hysterosalpingogram. It's an x-ray. These squiggly lines are the fallopian tubes, so I can assess anatomy with this test. And I would also want to test her partner to make sure it's not a sperm issue as well, so we can do a semen analysis. So this is in combination with those blood tests and ultrasound would be the basic fertility testing that I would do for a couple that comes to see me. All right, let's talk about Parenthood Options that are going to be available to me after treatment. So I do have couples who come and see me, and I advise natural conception. That window of time or how long to try will depend. It will vary from patient to patient. It will depend a little bit on what their treatment was, how old they are, and sort of what their basic ovarian reserve testing looks like. If I have a patient whose AMH is already starting to decline, I'm worried about that window of reproduction, and that may be someone that I'll advise, why don't you try 3 to 4 months on your own, and if it's not successful, then we're going to think about different ways that I can help give you a little bit of a fertility boost. So attempting natural conception is possible. In general, for my cancer survivors, even if their numbers look good, most of the time I tell them to come back and see me within 6 months. The caveat will be is if I have a ER/PR positive breast cancer patient that's taking a hiatus from tamoxifen, we don't have the luxury of tons and tons of time. And so that window of attempting natural conception will vary based on that specific patient's scenario. There are fertility medications that I can give women to help them not make new eggs, but get more mature eggs. So in a normal menstrual cycle, we said you get one chosen follicle, one egg gets released. By giving women fertility medications, and those could be pills like oral medications, there are injections that can be given as well. I'm not making new eggs, but I'm getting more mature eggs. So back to our example where I had a patient or a woman who had 10 follicles that grew, one of them is mature, the other 9 die off. With these fertility medications, I might get 2 mature eggs or 3 mature eggs and lose 7 or 8. So that's how these drugs will work. There's a medication called Femara. It's an aromatase inhibitor. It's called letrozole. We do use it as a hormone suppression medication for premenopausal breast cancer patients. We can also use it as a fertility drug. It can get multiple follicles to develop. And there's another medication called clomiphene or Clomid, and those are both, Femara and Clomid are both oral medications, but I tend to use Femara because it keeps estrogen levels really low during treatment. And then we have assisted reproduction. So those are the things that I can be helpful with. You would see a fertility specialist. There are things called intrauterine insemination or IUI. That is where IUI is oftentimes used in conjunction with fertility medications like the pills or injections. Get 2 or 3 mature follicles to develop or eggs, and then a partner produces sperm. We wash the sperm, place it through a small straw, through the cervix, so we get the sperm as close to the eggs as possible, and allow for natural fertilization, which would happen in the fallopian tube. Depending on the age of the woman, for women who are under the age of 35, likelihood of success with IUI, with medicines like letrozole or Clomid or injections, 8 to 10% per attempt, not huge. And that's in the setting that all the testing looks normal. Alternatively, we have all the high-tech stuff, all the fancy stuff that I do, which is called in vitro fertilization. And that process is depicted here. When I have women who do IVF, what she does is takes injectable medications. So it's injections that are administered for about 10 days. They are self-administered. And we use transvaginal ultrasound. So this is an ultrasound. It has a special guide wire. This is on ultrasound what the ovary looks like. These big bubbles are follicles. They have fluid, and the egg is floating around in the follicle. I can, under anesthesia, use this ultrasound with the needle, puncture each one of the follicles, aspirate or drain all of the follicles, collect the fluid. That fluid is collected in a little test tube, and then that test tube is passed off to my embryologist. They take a look under a microscope, and they tell me if we found an egg in that fluid. And then I have women who, if they want to freeze eggs, we can take these eggs. If they're mature, those eggs can be frozen. Or if a patient is ready for pregnancy, we'll go ahead and take those eggs, fertilize with sperm, create an embryo, and then the embryo can be placed inside the uterus. So everything is happening in a petri dish in a lab, not in the fallopian tube. Likelihood of success, again, depends on age, but for women who are under the age of 35, in general in my practice, likelihood of success from IVF is going to be about 65 to 70% per transfer every time we put an embryo in. So much, much higher likelihood of success, much, much more expensive. So sometimes we will start with something like IUI before we have to do a more aggressive treatment like IVF. Sometimes I have women who come to me and ask me, what if I have a cancer gene? So I have a couple of different cancer genes up here. The ones that most of us are going to be familiar with are going to be BRCA, but we also have newer mutations, P10, ATM, CHEK2. I've had patients who've had all of these different types of gene mutations that have come to see me. And one of the concerns that they have is about transmission and maybe having their children also have these genes. Most of these genes, so BRCA1 and 2, are autosomal dominant. So that means that every offspring has a 50% chance of inheriting that gene. And they may come to see me for something called preimplantation genetic diagnosis. So what we can do is I have women who, or families or couples that come to see me, we do IVF. So this is a fertilized egg here. It has one single cell, and this is what happens in my IVF lab. So the cells will divide. So one cell divides into 2, then 4, then 8, and then exponentially grows. So then here by day 5, so this is 5 to 6 days after I've harvested eggs, you have this advanced stage embryo, and this embryo has about 100 cells. So it started with one cell, and over the course of 5 days, it developed into a structure that has 100 cells. And at this point, the cells on the inside of the embryo are the ones that ultimately become the baby. The cells on the surface are the ones that become the placenta, but all the cells have the same genetics because it's that single cell that just kept replicating. And so there's a procedure we can do where we can remove 3 or 4 cells from the surface, not disrupt the baby cells, and create carbon copies of the DNA in those cells, and then test them for different types of genetic conditions or gene mutations. There are times where I have patients who have primary ovarian insufficiency. It's a young woman who's actually gone through early menopause, and fertility treatments are just not possible. So then we think about, are there any other alternative parenthood options? And so I have had women who have gone down the path of using an egg donor, and that could be a donor who will then, the donor goes through ovarian stimulation, so it goes through all the shots, and the egg harvesting goes through the egg retrieval, and then my patient is the recipient. So she's the one where I'm preparing her uterus to be able to transfer this egg that was created, or this embryo that was created from an egg donor, and place it inside her uterus. So that's called egg donation. That can be anonymous, so it could be there's no connection. There are different agencies that have anonymous egg donors, and these are women who many times they themselves have had infertility issues in their own families, and that's why they're motivated to be egg donors. The cost, in here I put some general costs. It is going to depend on, center to center. There are geographical differences, so, the East Coast might be more expensive than West Coast. There's going to be some variation, but I put on here general cost of what these alternative options may run. So egg donation is going to be around $25,000 to $35,000. There's also donor embryo. So these are patients that may have gone through IVF and have finished their family, and they have extra embryos that they will donate to different programs. So these are already created embryos, and I've had patients who have taken advantage of that and have been successful and have had children. There's also gestational carrier or surrogacy. I have had breast cancer patients who have gone through IVF before treatment and then came back and used a surrogate and had a baby that way. Gestational carrier, there are agencies that work with gestational carriers, so you develop a relationship with the agency, and then I would be involved in preparing for the embryo transfer. Use of surrogacy can be very, very expensive, and for a lot of patients, cost prohibitive. The general cost for a gestational carrier is around $80,000 to $100,000. There are state restrictions. Reproductive law, especially in the United States, are very complex, and so the different states will have different regulations about surrogacy. So, for example, in the state of New York, surrogacy is illegal. You can't do it. And so when I have patients that use a gestational carrier, one of the key components is having good reproductive attorney representation, because there's lots of legal complexity with this. And then adoption. And depending on the adoption agency, this can also be a fairly, expensive option as well. And then lastly, we're going to talk about, is pregnancy safe for me? What I advise patients is that, when thinking about, is pregnancy safe for me, you have to talk to your oncologist, because your oncologist is going to be such a key component about giving us information about timeline. And so because your oncologist is going to know everything about your specific cancer history and the specifics about risk of recurrence. And so it's usually a combination of collaboration among three people. It's going to be oncologist, a fertility specialist like myself, and then I have all of my cancer patients, regardless of what kind of cancer they have, see a maternal fetal medicine specialist, MFM. And there is the Society for Maternal Fetal Medicine. These are high-risk obstetricians. They specialize in women who have different types of medical illnesses and taking care of them in pregnancy. So all of my cancer patients will see an MFM specialist for preconception counseling. And what MFM will do is, depending on what kind of treatment a woman had, there is special type of surveillance that needs to be done during pregnancy. So for example, if I have a breast cancer patient and she had adriamycin, so one of the things that we do before we even think about getting pregnant is I have her see MFM. We do a baseline cardiac echo. Adriamycin is associated with cardiac toxicity. During pregnancy, a woman's blood volume increases by half, because so much blood is traveling to the placenta, to the baby through the placenta. So her heart really has to be strong. And so we get a baseline cardiac echo to see what her baseline function is. And then my patients get cardiac echoes every trimester. And that's coordinated through MFM. And then depending on the specific situation, that woman might need extra growth scans, extra monitoring during pregnancy, and an MFM specialist would take care of all of that. As a fertility specialist, in my practice, I only take care of patients until they're 8 weeks pregnant. So I take care of them in the very early first trimester, and then I transition them to MFM. And so when I have patients see an MFM specialist, it's a seamless transition, because they've seen me, and then they go right into continuing their prenatal care with maternal fetal medicine. What we know is that for premenopausal breast cancer, in the big studies that have been done and big meta-analyses, that for many survivors, pregnancy appears to be safe. Risk of recurrence does not seem to be increased in survivors, and in some studies, overall survival actually is improved in women who have had a pregnancy. If we look at one of the concerns, yes? Yes. Oh, great question. Yeah, so the question was, what about breast cancer patients who are getting hormones for IVF? So yes, there have been studies that have looked at premenopausal breast cancer patients and compared women who are the same age, the same stage, compared women who went through IVF treatment or fertility preservation with fertility drugs compared to those that did not. Risk of recurrence was no different there. And overall survival in that study was slightly better for the women who went through treatment, through IVF treatment. Yes. If we look at large population studies and looking at perinatal risk profiles, so this is preterm labor, different types of complications that can happen in pregnancy, these large population studies demonstrate a similar risk profile to the general population. So there doesn't seem to be an increased risk of preterm delivery or preeclampsia, things like that, in breast cancer patients. Overall survival is improved in women who've had a pregnancy in many studies, and breastfeeding is possible, except in cases of direct radiation to the breast. So if women have had direct radiation, one of the concerns can be something known as mastitis. Mastitis is an infection in the glands that produce milk. And the reason here is because what obstetricians have told me is that it's just very, very difficult to be able to treat properly mastitis because the antibiotics and different treatments are just not as effective. Or in the worst cases of mastitis, actually a surgical resection of the tissue has to be done, and that can be very difficult after a patient has had radiation. And then a common question I get asked is how long to wait for pregnancy? Well, that will really depend on your oncologist and your care team, depending on what type of tumor cell you had, your treatment, risk of recurrence, what does that interval usually look like. The typical interval, which I have seen in working with oncologists, is usually about 2 years after completion of treatment. A lot of women are going to be on tamoxifen, and so there is currently a clinical trial going on looking at what's the right interval of time to be on tamoxifen before taking a hiatus, because we actually don't know what that is. We don't know if women should be on tamoxifen for a year and then take a hiatus and then attempt pregnancy, or should it be 2 years minimum and then the hiatus? But there's a large multi-center clinical trial that's answering that question, so the data should be coming out soon. But what I have seen, at least in the oncologists that I've worked with, is 2 years after completion of treatment, taking patients off of tamoxifen, there is a washout period for tamoxifen. It has a very long half-life, and so the typical window is 12 weeks of being off of tamoxifen before attempting pregnancy. And the reason being is that tamoxifen is considered pregnancy category X. It's a teratogen. It is associated with fetal malformations, and so women should not be trying to attempt pregnancy while they're on this or within 12 weeks there. There's lots of great resources for fertility and breast cancer. So this is Susan G. Komen. This is my website here at CCRM. You can Google that, YSC. There's also this great website called myoncofertility.org. They have great videos. They have a lot of interviews, things like that. So these are going to be really good resources there. All right. And then if anybody has other questions, I'm happy to answer them.
So if I had frozen my eggs, would I rather use the eggs that had been freezed, or should I attempt natural pregnancy? Because are the sleeping eggs are affected by chemo in like a childbirth defects in the future?
Thank you. That's a great question. So if I have a patient who has done fertility preservation, so frozen eggs or frozen embryos before she goes through treatment, sometimes they'll come back to me and say, should I try natural conception, or should I go ahead and freeze or use my frozen eggs? Really good question. So much of it will depend on, if that patient is on tamoxifen, and does her oncologist want her, did her oncologist give her a finite period of time in which she could attempt pregnancy, and then is there a time period that we have to restart tamoxifen? Because that will help me figure out, is it better to just use those frozen eggs because time to pregnancy is going to be so much shorter because the eggs are already frozen, or in the case of embryos, the embryos are already frozen, so for me to prepare her for a transfer can be very, very quick. If I don't have that specific time pressure, I do advise women, depending on age and if the other numbers look pretty reassuring, that they can attempt pregnancy on their own. The interval of time is usually about 3 to 6 months. If it hasn't happened, then we talk about going ahead and using frozen eggs. depending on what kind of chemotherapy that woman was exposed to, that also helps me counsel her, because if she got something like carboplatin or Taxol, we won't know if those eggs have been affected until she's in pregnancy. In general, though, if you look at fetal malformations or birth defects in breast cancer survivors, the prevalence of that is really no different than the general population. So overall, that seems to be reassuring, but there is no way of knowing until pregnancy.
Yes. My question is threefold. One, don't forget. Yes. Oh goodness, it's gone. Yes, it's come back. When you're attempting IVF after 2 years or 18 months on tamoxifen, do you have to go through the whole injections and process of, injecting yourself on the hormonal stimulating drugs? And the second question is, my God, I remember it.
That's okay. So I can answer your first question. So is it in someone who has already had embryos frozen or someone who's starting fresh? Okay, so if I have a patient who's undergone fertility preservation and has eggs or embryos frozen already, there is some medications that are required to prepare for implantation, but it's not going to be all the injections. The focus really, so the injections were really to collect lots of good, healthy eggs. When we get to the embryo transfer, I am so focused on the uterus and the lining, the uterine lining, and making sure that it's nice and fluffy. So there are going to be medications that are used to prepare the uterus for implantation. Those are going to be hormones. And then depending on the center you go to, in my practice, we tend to use estrogen patches. So just estrogen that's worn on the skin. It helps build up the uterine lining. There are other formulations. It could be estrogen tablets. It could be estrogen that's taken orally to build up the lining. And then there is progesterone that's usually either in tablet form or injections. Yeah. And women are continued on those hormone support until about 10 weeks gestation. And after 10 weeks, so the placenta in a pregnancy starts to form at 6 weeks, and it completely is formed by 8 to 8.5 weeks. And so after 10 weeks, all that extra hormone support that we're giving a woman can be discontinued because the pregnancy and the placenta and the baby is making everything that it needs for the rest of the pregnancy.
The second question was, so what can one do to improve success rates on the first implantation of embryos?
So the things that can improve implantation, so there's a combination of things that I look at for my patients who are getting ready for a transfer. So it's how fluffy the uterine lining is. We look at estrogen and progesterone levels as we're preparing for implantation, and what the quality of the embryo is, how good the embryo is, because depending on what the quality of that embryo is, the probability of being successful can be different. I do have some patients, I would say about 90% of my patients that do IVF will also do genetic testing of embryos, so screening of embryos outside of what we talked about for pre-implantation genetic diagnosis, but it's looking at aneuploidy, so chromosome number of embryos, because as women get older, our eggs do age, and that's why when we looked at one of those early graphs about likelihood of pregnancy over the age of 35, the reason why it goes down is because our eggs are just not as healthy. The DNA within our eggs is not as healthy, and so the chromosomes can be affected, and ultimately the chromosomes in embryos. And so doing genetic testing or chromosomal screening of embryos can also increase the probability of being successful. I would say for most of my breast cancer patients, when we know that we have a finite period of time before they need to restart tamoxifen, many of them will ultimately do genetic screening of their embryos. Because there are some embryos, if the chromosomes are not correct, that embryo never would have had a chance to implant. So rather than spending time of doing transfers of embryos that were never likely to be successful, if I can screen out which ones are the ones that are the best ones to result in a successful live birth, that can help shorten that time to a successful pregnancy. Yep. Yes.
A lot of young breast cancer survivors are put on Zoladex or Lupron
Yes.
Instead of tamoxifen,
Yes.
along with an AI agent, or sometimes with tamoxifen. But my first question was, I was wondering how long it takes for cycles to return after stopping those agents.
So for medications such as Lupron or Zoladex, that can be so variable because part of it will depend on how long she's been on the medicines. So I have a breast cancer patient right now who is getting ready to do an embryo transfer. She was 28 when she was diagnosed. Her mom was 31 when she was diagnosed. She had BRCA1. And so that was a couple who ultimately did embryo banking with me before treatment. And then we did single gene testing, so pre-implantation genetic diagnosis for BRCA, and I did aneuploidy screening, so 2 sets of genetic testing. And she came off of Zoladex, and she's been off of Zoladex for 4 months and still hasn't gotten a period. For my purposes, when we get ready for pregnancy, I'm less worried about that because there are things that I can do to induce a period or give hormone support or things like that to help for conception or for pregnancy. But that window of time off of Zoladex can be so variable. It could be 3 months. It could be a year.
Okay.
Yeah.
And the second question I had was, for those of us who do need resources, financial resources for fertility treatments, you know of organizations like, I know Livestrong, but those who specifically help cancer patients after treatment, like not with assistance in freezing eggs before treatment, but after treatment.
Yeah, so that's always a challenging thing too, is because even for a lot of the assisted reproduction, we talked about some of the costs that are associated. It can be so prohibitive for patients. So so Livestrong is going to be a great resource. There's going to be a few other ones as well. And you can also look to the center that you go to, so your fertility specialist, because different places will have resources within their practice that can be assisting patients who are who have cancer and through treatment. So for example, at our center, we have some resources for cancer survivors that are going through assisted reproduction. There are going to be some of the pharmaceutical companies as well, because the medications can be so expensive to freeze eggs and embryos. The medication costs for patients can be anywhere from $3,000 to $8,000 alone. So I think that your fertility specialist can be a great advocate to help direct you to the right places.
We have time for one more. I saw your hand first.
I have a question about the gestational carrier.
Yes.
How do you get connected with an agency, and then what does that process look like? Does that surrogate come to the, do they come to the center, or do you get the
great. Okay,
to them?
Great question. So when I have patients that use a gestational carrier, and I do a fair amount of gestational carrier cases. The way it works, at least in my practice, and different IVF clinics are going to have a little bit different process, but I can share with you what happens at CCRM. So what a patient will do is they work directly with an agency. There are certain agencies that my patients tend to work with. So Conceivabilities, for example, is one. Exceptional Surrogacy, I think, is another one. Circle Surrogacy is also an excellent one. And so patients will work directly with the agency, and that agency will have a database of candidates that could be gestational carriers, and they've gone through that screening process with the agency. In my practice, when I have a couple or a patient that's using a GC, gestational carrier, once they've identified a potential candidate, then I request all of the obstetrical and medical records on that carrier, and we review them. So we have a very extensive screening process, because an agency may deem a particular woman as a good candidate, but I see something in her obstetrical history or medical profile where I am concerned about her being a good candidate for my patient. And so we do this initial screening. If that GC is an appropriate candidate, then that gestational candidate comes to CCRM, so they come to Colorado. I do all of the testing, so uterine evaluation, medical testing, infectious disease. So anytime you use third-party reproduction, which is donor egg, donor embryo, gestational carrier, donor sperm, there are Food and Drug Administration regulations. So there are government regulations, and there are very specific exams and tests that have to be done on all the parties that are involved. And so we do that entire battery of testing on that gestational carrier candidate. If we deem that person to be an appropriate candidate, then she can go back to her home state. And many times I have patients that don't live in the same state as their GC, and we can make that very, very feasible. I will be preparing that gestational carrier for embryo transfer. She can do it from afar, and then she comes to Colorado for the actual embryo transfer. And that trip to Colorado is for 4 days. She flies out the day before the transfer, we do the transfer, and she flies home 2 days later. And then I can manage her pregnancy from afar. My practice is a little bit unique because 70% of my patients don't live in Colorado. So I take care of so many patients that don't live in Colorado or even in the United States. So we're really accustomed to taking care of patients remotely there. But that's in general what the process is for use of a gestational carrier. Okay, perfect. Well, thank you so much. I'm so glad that all of you stayed. And if you have other questions, feel free to come up and ask me.